welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today in the show, we have Jeb Dunkelberger. He is CEO of Sutter Health Aetna, and he wrote the book, Rich and Dying, an Insider Calls BS on America's healthcare economy. There's an excerpt from that book on Kevin MD titled, Our Healthcare System May Be Failing, but It Isn't Broken. Jeb, welcome to the show.
Hey, thank you so much for having me.
So we'll get into your book and excerpt in a little bit, but first off, can you share your story and journey to where you are today?
Yeah, no, currently I am the CEO of a regional health plan called Sutter Health Aetna, which is the combination of both Sutter Health, obviously, and Aetna, which is a CVS company. Prior to that, I did a few startups in Silicon Valley, renal care, as well as a robotics company. And then before that, I worked in the payer space. I was within the Blues family at Highmark. And then I also worked at McKesson on the provider side. And then I actually started my career in advisory at Ernst & Young as a health economist.
So as a CEO of a health plan, so tell me some of the challenges that you're facing today.
Well, I mean, obviously everyone's going to kind of vert towards, COVID. I think one of the most interesting statistics right now is that if I was to break down COVID cost, hospitalizations are about $6 PMPM for us right now, but testing is about $7 PMPM for us right now. So it's a very unique situation that we're in. If I was to step away from COVID and look at some of the other areas that we're focused on, there is this kind of blossoming, loose constellation of point solutions that have been coming out and trying to make sense of all of that and ensure that we're not just ushering in and trading our problems by bringing in a bunch of point solutions that further disintermediate care. So, those are probably two of the biggest things that we're facing right now within our day-to-day work.
And in the next 6 to 12 months, from your perspective, what would you say is some of the future trends of the healthcare industry?
Next 6 to 12 months. Well, I think that provider networks from a payer perspective are going to look a bit different. Obviously, virtual care has been ushered in during this pandemic, but actually seeing now that the network is going to include both virtual providers as well as, more like digital therapeutics. I think that's a very interesting space that you're going to see a big push in the next 6 to 12 months. Another area is the hospital price transparency and transparency and coverage. Obviously those things were hospital price transparency was launched this year in Jan 1. Transparency and coverage is coming out Jan 1 of next year. And when I look at both of those, again, it's kind of in the theme of consumerism. And as many people state, consumerism today only exists with about 5 to 10% of healthcare. Most of healthcare is not shoppable. But I would predict that over the next 6 to 12 months, we're going to see the federal government take a pretty strong stance. And that's really going to be our beacon or our line of sight into where things are heading over the next year to 2 years. And that can open up a whole number of new issues in terms of transparency if employers and insurance brokers get their hands on that data and know how to use it. So again, I'm looking forward to that because that's actually where I believe that the market needs to begin to head.
For those who aren't familiar with the status of price transparency, tell me what the situation is right now and tell me what you anticipate the situation to be in 12 months from now from a consumer standpoint.
Yeah, so right now the current situation is that there is a federal mandate for all hospitals to post 300 shoppable services on their website. It's supposed to be machine readable as well as consumer friendly. The current state of the state is that, less than probably 15% of hospitals are fully compliant at this point. The current penalty right now is about $300 a day, if I remember correctly. So obviously that's a de minimis amount in terms of total revenue. And so the Biden administration has come out and said, actually, we're going to increase that penalty to a pretty high number to actually make this felt at the most senior levels of the organizations that they're trying to go after. From my perspective, what we're going to see is, although there's a lot of contention around this topic, hospitals should not be scared of putting out the prices that they have negotiated with insurance carriers. The issue, though, that I think is happening is the way that is done today is a very complicated process. If you go to most hospital executives, they might not even know their cost structure. But when you say, how much is it going to cost for a colonoscopy? It's not always easy to say exactly what that price is based upon the myriad of factors that go into figuring out a patient's copay or co-insurance. And so where I think things are going is that is going to become much easier and user-friendly. I think that you're going to see the government continue to take a stance on this. And insurance carriers are going to have to reinvent themselves a bit in terms of defending their relevancy in this equation, right? Because they should be the steward of the dollar. They should be the watchdog of the spend. They should be working on behalf of the consumers and the employers that they represent. So, again, I believe that over the next 12 months or so, through the federal government taking a stance, you're going to see a lot of industry incumbents decide which path they're going to go down. And some may even blaze a new trail, and there are going to be some pretty big incumbents that do that.
All right, let's talk more about our healthcare system. You wrote a book on it titled Rich and Dying, an Insider Calls BS on America's Healthcare Economy. There's an excerpt from your book on Kevin MD titled Our Healthcare System May Be Failing, but It Isn't Broken. Now, for those who didn't get a chance to read your excerpt or your book, can you just walk my audience through it and share the story of why you decided to write it?
Yeah, I mean, at the highest level, the book is broken into three pieces. It kind of walks through where the industry is today and really demystifies the two ends of the spectrum that I find most people falling into, which is Medicare for all or a free market. And I, break down in the book basically why neither of those things are really the panacea or the answer, and even why some of those things can't even exist today. The second part really talks about insurance companies and all the different programs that have been implemented in terms of self-reform, right? Getting this healthcare system back on track. And then the final piece really talks into the future and what I believe is needed in order to correct the current state of affairs. I think at the highest level, it's just important to remember, and the reason why I took such a stance of rich and dying and Insider Calls BS on America's healthcare economy is 1 in 7 people is employed by healthcare. Healthcare tends to be the largest employer in any state. It's either an insurance company, a health system, or Walmart. So if you think that reform is going to come at the local level through politicians, I think that you're gravely mistaken. And so from my perspective, writing this book allowed me to really explain why I believe pieces, although they look like they're fixing the broader problem, we've maybe made a shtick of reinventing healthcare 2.0, healthcare 3.0. And we're not really taking the actual steps needed to truly transform the system. And so after, being in this for over a decade, working in provider, payer, technology, and advisory, I felt like I had enough perspective, to share at least my point of view in terms of where things need to go. And again, I've, God willing, 20 years left in this space. So hopefully I can see some of these ideas through.
So in your excerpt in particular, you take the viewpoint that our healthcare system actually is actually quite positive. You said that you want to start with our healthcare system is perfect. So from a position of strength. So that perspective, I'm interested in exploring more, because whenever I talk about healthcare policy on the show, it's always, what's wrong with our healthcare system. So you start with what's right with our healthcare system and kind of work from there. So let's start with there. What's right with our healthcare system?
I think at the highest level, what's right with our healthcare system is that we have an ample supply of access, right? We are lucky compared to many other countries. We have more providers per capita than just about anywhere else. On top of that, I think from an acute care perspective, we also are very fortunate. If you were to take even one step further, the fact that our healthcare sector employs 1 in 7 people, that to me is a success. It is a driver of our overall economy. And that is just a real point that everyone just has to kind of swallow. We can't change that, right? The master's programs, the doctorate programs, all of the different specialties within healthcare, right, they employ a lot of people. So it's always funny when I hear people say, oh, well, healthcare spend 30 to 50% of it is fraud, waste, and abuse. Well, then you also have to say that 30 to 50% of the spend is employing 1 in 7 Americans. There's 20 million of them that you would have to think about, where would you put them if you got rid of that fraud, waste, and abuse? So at least in my mind, that is where the system has its strengths. And then I also think that the system responds very well to the current incentives that are put in it. So in terms of the economic drivers of that model, the program is working. I mean, if you have a fee-for-service model where you only make money when you see a patient and you treat them, then that's what you're going to get. So if we really want to see this change to more of a population health preventative type of model, you have to change the incentives that lay within that. And furthermore, you have to change the compensation structures that sit within the provider world. And we also have to look at all the other industry incumbents, including the payer, including diagnostics, including pharmaceuticals and biolife sciences, and say, what is your relevancy to adding value to this program? And if we can't prove it out, we can't pay you big dollars for it.
Now, in your view, what would you say are the top 2 or 3 areas that need the most reform in our healthcare system?
Well, I think if I was to go after the top 2 or 3 in terms of reform, first and foremost, I think that we need to get the incentives correct. We have seen in a lot of microcosms how sharing risk and sharing accountability with providers has an overall net positive impact, not just on quality of care, but also on the total cost of care. And so I think that's number one, is we got to start with the incentives. We got to get people paid for doing the right thing. I also think that it's really important that we start creating a shoppable experience for consumers. Right now, there's just too much murkiness. And as I said to you when we were first getting on the phone here and online, my fiance is a trauma surgeon at USC LA County. And I look at that and I say, there's a very, very small percentage of care that is not shoppable. That's that acute, traumatic incident. But we have to do a better job making it so people can actually navigate the system. And that probably takes me into my third area, which is actually being able to move around the system. There's no price transparency. There's inelastic demand. There's no easy entry or exit into the market. And so we need to make this more consumer friendly. So those are probably the three areas that I focus on without getting too deep into the political side of the house.
Now, I think one of the criticism, of course, of our healthcare system you mentioned is the increasing costs, and there are studies, according, like for instance, the Commonwealth Fund, saying that the quality that we get for the money we pay isn't comparable, to some European countries or countries that use a more socialized or nationalized system. So, what's your response to people who bring those statistics up?
Well, look, I look at those statistics as well, and I trained and worked in England for a few years, and what I would tell you is this. We spend $115,000 on healthcare every second. So by the time I finish the sentence, we probably already racked up $1 million. The size of our system is the size of 2 Russias in terms of the GDP. So when you think about how much money is being spent here, and you think about the outcomes that we're getting, there's definitely a disconnect. I think there's some wonderful studies that have been shown that, in other European countries, they spend twice as much on social services, but half as much on healthcare compared to the United States. I completely agree with that. When you see somebody walking down the street and you say that person's healthy, is it because you know the provider they go to, or is it because you look at all the other social determinants of health that you can kind of configure from walking, talking, and listening to somebody? I think, again, the stats protect that. 90% of healthcare is determined by things that are outside of the clinical setting. And so we need to move into that space. But again, that ties back to aligning the incentives. If you go more towards a capitated payment model where the provider is going to make money by doing preventative medicine and keeping those avoidable or impactable utilization trends down, we will see more providers move into the social determinants of health space. And that is such a buzz term right now. But I do believe that getting into the housing, nutrition, is really important. And I find myself constantly going back to my undergraduate degree in human nutrition, foods, and exercise. And I was always praying that this some way would become relevant in the future. And I think that it surely is. So right now, 2021, I see us taking a shift away from clinical interventions and moving much more upstream into the social factors.
Now, currently, the Biden administration is strengthening the Affordable Care Act, so there is a possibility of a public option. Is this the right path for our healthcare system?
Here's what I'd say. You can look at the American Rescue Plan, and we increased access and eligibility for the ACA products to 400% of the FPL. You also look at the fact that federal poverty level. You also look at the fact that we may drop the eligibility for Medicare to 60 years old. Do I think that's the right thing? Philosophically, yes. I do think that we should have universal care and access to care. What I am worried about, though, is that right now, most hospital systems are running on 1 to 2, maybe 3% margins. They're coming out of a pandemic, or they're still in the pandemic, and they're fighting for their life right now. Where they make their money and their margin is on commercial insurance. And so that is the employers. And I'm not sitting here saying today that employers need to continue to foot the bill for the rest of the country, paying both a Medicare tax as well as paying, 2, 3, 4 times the reimbursement rates for commercial insurance versus government funded. But as you expand the government funded lines of business and more people go onto that, you're going to flirt with a math problem. So this is not political. It's just a math problem that you're going to tip the scale the wrong way and hospitals will go upside down. Mm-hmm. So we have to do 2 things simultaneously. 1, optimize the cost structures of all of our care clinics, which can't mean firing people. Again, this is a jobs program in some respects, and we have to think about that. And then 2, we have to think about, as we increase access to care, if it's government funded, is that reimbursement enough to protect those businesses so that they can actually survive? Because right now, I think there's enough analysis done that if you were to increase eligibility by the 400% and drop Medicare eligibility to 60, a lot of hospitals are going to go upside down. So although philosophically I agree with it, I think mathematically there's still some work to do before we just go about making emotional decisions on who has access to care. We have to think about just the hard and true fact, which is there is a math problem, and we need to figure out how these hospitals survive.
We're talking to Jeb Dunkelberger. He is the CEO of Sutter Health Aetna, and he's the author of the book, Rich and Dying, an Insider Calls BS on America's healthcare economy. There's an excerpt from that book on Kevin MD. Our healthcare system may be failing, but it isn't broken. Jeb, I want you to speak to the Medicare for All proponents. You did mention a couple of obstacles to implementing a system like that in the United States. For instance, the number of people who already work with healthcare, they're going to be essentially looking for new jobs. And you talk about the disruption on hospitals, especially rural hospitals, such a system would impact. What's the scope of the change if something like a Medicare for All system were implemented in the United States?
I mean, the loose analysis that I did actually, probably 2 years ago, where we thought that there'd be well over 1 million jobs lost, up to 3 million jobs lost. Medicare for all, I don't believe is the answer. Do I think that the federal government should provide a safety net? Absolutely. I'm more in favor of something, if we're going to go down that track, and I had to kind of take the lesser of two evils, probably a Medicare Advantage for all, because I do believe that that still allows the private sector to play a role in innovation. As I look at my local DMV, as I stand in a TSA line, or maybe even just look at the fact of how do we respond to the pandemic from a federal perspective, I do not want the federal government playing that large of a role in care delivery. So a Medicare Advantage line of business, I think actually plays well. It allows the private side to really drive innovation forward, continue to monitor quality and cost. And then the federal government is left to really, sit back and regulate that. I think that is probably an even path that gets enough of the innovation and private sector involved, but at the same time provides the access that we're discussing.
Now, I'm a primary care and internal medicine physician, and you did mention some trends that we may be looking for. So go more specifically. So doctors like myself, what do we have to look forward to in the next 3 to 5 years?
I think that if there's ever been a great time to be a primary care or family doc, now's the time. But you got to step up to the plate, because I also realize that 70% of providers today are employed. And so typically they are just following what the larger system is doing or the employer is doing. But now is the time. The average primary care provider controls about 5 cents out of every dollar that's spent in healthcare, but they have the ability to influence well over 50 to 60 cents out of every dollar. They are really the conduit to us seeing, utilization change, referral patterns change. So as more transparency comes out about who is high quality and low cost, it is really on that primary care doctor to go to the payer and say, hey, I want to take responsibility for that dollar. I want to take responsibility for more than just 5 cents. And I think that now is the time to speak up. There are wonderful companies out there that have already kind of shown a path here. Iora, One Medical, Aledade, Oak Street, right? There's a litany of them that you can look at, but the business models are not rocket science. And so as I'm looking out to even my friends that are family doctors, I'm constantly telling them that now's the time. Do not sit back and wait for someone to come and tell you how to do it, because by then you're just talking about another employment model. Take a step forward, talk to your largest payers that are in the market. The commercial side is a wonderful area to continue to break into. And as I see it, more and more of the money is being spent on a delegation of risk. So more providers are coming in saying, we want to take a capitated payment or a bundled payment or some upside downside. Shared savings is maybe what you hear. You can only cut the pie so many times. So if the risk gets all delegated, it may be too late for a primary care doctor to step up and say, I'd like to take risks, because it may already be assumed by another entity. And so you really do have to start moving sooner rather than later.
And my final question, what's your take-home message that you want to leave with the Kevin MD audience?
Take-home message is keep fighting the good fight. I know that it's tough right now. If you look at COVID, if you look at the federal government, there really are, just a few reasons to stay in healthcare right now. And there's a ton of reasons to just stay home. But what I would say is keep fighting the good fight. We need you. And I'm grateful that I've had the opportunity to talk to you all today. So again, thank you for what you're doing out there. And I look forward to seeing this into the next chapter, because that's where the country needs to go.
Jeb, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you.